those of you that don't know me, I'm Chris Myskowski. I'm a professor in the departments of physiological nursing and anesthesia and co-director of the Pain and Addiction Research Center. We've got Judy's slide up. Could you go back to Anna? Great.
Yeah.
Yeah. For those of you that are knowledgeable about PARC, we are a transdisciplinary center that spans uniquely, I think, the clinical and research communities at UCSF to really advance the science and care around pain and addiction. And if you're interested, that's the QR code to become a member of PARC as well as to get on our mailing list. If I could have the next slide. Just as a preview for our next two seminars that are in alignment related to the management of pain in people with cancer. Our next speaker on May 22nd, same time, is going to be Jessica Merlin. For those of you that don't know her, she is a professor at the University of Pittsburgh, and she's going to do a cancer pain translation seminar. And then the June meeting will be with Dr. Anna Shah, who is an associate professor at our own UCSF, and she's going to do a seminar with an actual patient. But the theme for today, and it's my privilege actually to introduce to you Dr. JPaice. And if I could have the next slide, Emma. Judy is not only a colleague, but a really, really good friend. We've worked together for a long number of years, more than I actually want to say. Currently, Judy is the director of the Cancer Pain Program in the Division of Hematology and Oncology and a research professor of medicine at Northwestern University in Chicago. She's also a member of the Robert H. Lurie Comprehensive Cancer Center. Currently, Judy is a member of the NIH HEAL Initiative Multidisciplinary Working Group. She has served as president of the American Pain Society and secretary of the International Association for the Study of Pain. She also currently is a member of the National Comprehensive Cancer Network's Adult Cancer Pain Clinical Practice Guideline, one of the Bibles for people who care for people in cancer with cancer-related pain. And most of Judy's work focuses on how to achieve superb relief of pain in people with cancer. She's been to 6 continents, lecturing on pain and palliative care. She serves on the editorial board of a number of journals, including the Journal of Pain and the Journal of Pain and Symptom Management, and she's published over 200 scientific papers. Of note, Judy has been named one of the 30 visionaries in the field by the American Academy of Hospice and Palliative Care. And in 2023, she was named a fellow of the American Society of Clinical Oncology. So it is with great pleasure that I asked Judy to present her paper, Cancer, Pain, and Opioids, Pandora's Box, quote unquote. Judy, we'll switch the decks. I can't wait to hear this talk.
So thank you. Thanks, Chris. And let me just get this into the right view for you all. Well, I wasn't anxious until I see the distinguished folks who are observing this presentation. So thank you all for taking the time to be here. You'll see in a little bit why I'm calling this presentation Pandora's Box. What I'd like to do through this time we have together is talk first about how we got into this mess related to opioid therapy in people with pain. And I'm always going to be referring this related to people with cancer. So my lens is through people with cancer pain. I follow a caseload of close to 200 patients. The majority are people with cancer. I also, because we are a hematology oncology division, I have about 15% of my patients are individuals with sickle cell disease, and a few are people with hemophilia. Most are older people who are HIV positive from when the blood supply for factor was not safe. So they have a lot of arthralgias and arthropathies and other significant pain syndromes. So after we talk about the problems, then we're going to talk a little bit about some of the evidence, and we're going to finalize this talk with a little bit about some of the complex cases. I have nothing to disclose. So you all know that cancer pain is a huge problem, and that globally there's a large number of individuals who are diagnosed with cancer, many people who die, unfortunately, and unfortunately, much of the burden is in low to middle income countries, We have instead made really amazing advances in the care of people with cancer. And as a result, we have many, many long-term survivors. The cost of that has been significant numbers of individuals with chronic pain. Aligning with cancer pain, we also see that a good number of in our population in the US have chronic non-malignant pain. And in the National Household Survey, approximately 50 million have identified as having chronic pain daily or almost daily. And of those individuals, 17 million report something called high impact pain. And this is where there's a substantial restriction in activities of daily living. Now, that number comports pretty easily or equally with the numbers of people with heart disease in our country and the numbers of people with cancer in our country. And the consequences are profound. We see lost productivity, high healthcare costs, increased risks of depression, Alzheimer's, other dementias, and suicide and substance misuse. And then there's this other epidemic that you've all heard about. And I know this slide is getting a little bit older, but I really appreciate how the CDC has illustrated the three waves of the opioid epidemic. And unfortunately, what has been occurring since 2019 is more of the same. So in the beginning, the epidemic was fueled by prescription opioids, but numerous laws were placed. There were lots of changes in the formulations of our products. And as a result, people started to turn away from prescription opioids, in part because of access and expense, and they turned to illicit heroin. And then our heroin supply is now largely composed or infected with, if you will, fentanyl. So illicit fentanyl is truly the driver of our current high rate of opioid overdose deaths. More than 100,000 people in the US die annually from opioid overdose deaths. Now, not all of those individuals have opioids alone, but unfortunately, this is still obviously a significant problem. So how do we achieve balance, particularly when we are also trying to care for individuals with serious illnesses that are associated with significant painful complaints? So here's just one of those patients to illustrate a case. This was a patient that I cared for, and you don't have to be a radiologist to see he has an impending cord compression from metastatic prostate cancer. And this gentleman was 58 years old. He had had previous metastases that had been well managed through radiotherapy. And at times when the pain escalated, he would need opioids. After radiotherapy, his opioid dose would be diminished. He also had a history, by the way, of substance use disorder and was in a methadone clinic, but had been extremely compliant for years and really described himself as being sober for more than 10 years. Now, on exam, he had this radiculopathy, he had bowel and bladder sensation changes, sensory changes. His current medications were morphine, extended release, 60 milligrams every 8 hours, and morphine immediate release, 15 milligrams, Q4 is needed. And he was placed appropriately on dexamethasone, 8 milligrams per day. And he was seen by our radiotherapy department for simulation to begin radiotherapy treatments. When he was discharged with prescriptions for opioids. He had great difficulty finding the opioids at retail pharmacies. This was a gentleman of color. And that paper that was written by Sean Morrison and published in the New England Journal of Medicine more than 25 years ago, called "We Don't Carry That Here," demonstrating that opioids were rarely carried by retail pharmacists in neighborhoods that served people of color. This persists and is probably worse than it was 25 years ago. In addition to lack of access, there were insurance requirements for prior authorization that typically can take 24 to 48 hours, even with urgent requests. And then the pharmacies, and this is a newer barrier that I've been seeing in the last few months. I had another patient who, of course, on a Friday afternoon, we prescribed medication for him. The message came back that it needed a prior authorization at 4 o'clock on a Friday. That was not going to happen. The patient was willing to pay cash at the pharmacy and asked if he could use the coupons called Good RX, which can be very helpful. These pharmacies, this entire chain in that state, will no longer accept cash payments. This was a gentleman with pancreas cancer. The pharmacist asked, why isn't he in hospice? Not and really their business, but the patient wanted to try one more clinical trial. And he was enrolled in that clinical trial, which precluded his admission into a hospice program. So at 4 o'clock on a Friday, we could not get this gentleman his medications. It took 2 hours. I finally was able to get an urgent request for a prior authorization from his insurance company, but it was a lot of gray hairs for all involved. So what's the consequence of this? Well, the patients feel great stigma. They're afraid to take the medication. They start to ration the medication. There are numerous studies that demonstrate this. I see it clinically all the time because they're so fearful that they're going to run out of the drug. And the lack of medications leads to severe pain and often abstinence syndrome. So I wanted to highlight for you some of the obstacles that we're seeing so that you all from a research perspective might be interested in investigating or clarifying some of these obstacles. One of the obstacles we're seeing includes shortages of the medications. Right now, we've had severe shortages of hydromorphone, also called Dilaudid, from retail pharmacies. These are in part related to some of the DEA responses to the opioid epidemic. They have reduced the availability of raw materials to the manufacturers by 10% every year for more than a decade. So that becomes somewhat cumulative. In addition, there have been some supply chain barriers. Furthermore, these drugs are mostly generic, so if something does go wrong with the supply chain or with shortages, there isn't a huge incentive to ramp up production. I often joke that we don't usually see shortages of Viagra, although we are seeing shortages of Wegovy and Ozempic, but that's, I think, a very different story. There was a recent study published related to the American Society of Hospital Pharmacists looking at a wide array of shortages, and opioids and CNS drugs in particular was the number one group of drugs in terms of shortages. And in 60% of the time, we had no clue as to why there were these shortages. I've illustrated for you already these prior authorizations, and I can just tell you how frustrating this can be, talking to somebody, having to fill out forms verbally via fax. I mean, what businesses do work via fax in 2024? There are also, and this is still not widely understood, but algorithms are driving the identification of risk scores. One is called NARCS Care, and this is used by the prescription drug monitoring programs. And it's an algorithm that really looks at numbers of doctors seen and numbers of pharmacies. And I'm going to come back to this in just a moment. But that information is provided to physicians and to the prescription drug monitoring programs. AdvertD is another algorithm-based product that looks at genetic risks. There are also opioid stewardship programs. Now, that's okay. We all need to be mindful of when and how we use and prescribe opioids for our patients, but it's almost become anything but opioids, quote unquote, such that I will see patients who are doing quite well, that 80-year-old person who maybe has a prior history of cardiovascular disease, so shouldn't be on NSAIDs. They also have some renal compromise, and they were doing well with 1 or 2 tablets of a very low dose of an opioid for months and months. But the focus on getting people off the opioids now leads to them getting a prescription for gabapentin and acetaminophen and cyclobenzaprine. I feel as if everybody who leaves my institution leaves with a prescription for cyclobenzaprine. So 3 or 4 agents might be prescribed instead of that 1 or 2 tablets a day of a very low dose opioid. Our fellows, our trainees are not getting the education that they need to be able to appropriately prescribe opioids because the entire focus is not prescribing opioids. And then a lot of regulatory oversight so that we prescribers are being told we're doing the wrong things by prescribing opioids, even though many of us are working with cancer or sickle cell populations. Those populations are not being taken into account. And that leads to problems with access to care. Now, our conversation today is about opioids, but honestly, we see the same thing with access to physical therapy, access to integrative therapies, and other approaches, including cognitive behavioral therapies for people with persistent pain. I wanted to focus on this issue of these algorithm-based risk identifiers because it was in that very wonderful medical journal, the New York Times, just this Sunday in a guest essay. Say hello to your addiction risk score. So the NARC X care is based upon the number of doctors seen, the number of pharmacies visited, and then we really don't know what else because it's deemed proprietary and the manufacturers will not release what those risk factors are. Well, many of my patients have had to jump from pharmacy to pharmacy. In fact, I had a sickle cell patient just this morning that I had to re-prescribe his medications to 3 different pharmacies because they did not carry the medicine. And I have to tell you, you're probably thinking, well, Judy, why didn't you just call the pharmacies first? The pharmacies are so understaffed that they don't answer their phones. It's a huge issue. And then Advert D is a genetic test that it was approved by the FDA, despite the fact that its advisory committee voted unanimously against approval. So there's great concerns that people are being targeted. And unfortunately, there is a bias that people of color tend to be those who are targeted more than others. So that's a little bit about the state of affairs that we're in right now. And not to be too depressing, but I want to move on to talk a little bit about the evidence. Now, this was specific to cancer-related pain syndromes. The question I always hear from the medical students, the residents, our fellows, where do we start? And if we decide that opioids are appropriate, when do we use the opioid? Well, assessment is always key, and you all know how to assess. What's different than what we used to focus on? Instead of intensity, we look at function. And in fact, I ask patients, if we could do a better job with your pain control, what will you be able to do that you can't now? For some of my survivors, that may be return to work. For some, go to Disneyland. For others, walk around the block. And for some, I want to be able to hold my grandchild. Now I have something measurable. We institute a regimen, and a week later, a month later, we reassess and we determine, were you able to meet that goal? And if not, why? What was the obstacle? The other piece of the assessment that we didn't used to do in the past, quite frankly, is a good risk assessment. Now, there are screener tools that have been developed. I've tried using those. They've not really been validated in a cancer population. I like to be able to ask these questions so I can drill down. So I ask people, have you ever used cocaine, for example? And I warn them, I ask everybody this question. I don't care if you're 18 or 88. Have you ever used heroin? Have you ever used cocaine? Have you ever used methamphetamine? Have you ever used ecstasy or Molly? And so I'll hear from patients, yeah, I used cocaine when I was in college. And, I knew, I had to stop because I was an adult and had to pay for my rent and the roof over my head and the 3 squares a day. those folks I'm not so worried about, as opposed to the gentleman who told me I would do it every day if I could, but my workplace does random urine tox and I need this job. And I knew that when he was no longer working, we were going to have a very difficult time. And indeed we did. I also have been very surprised because it wasn't part of my training about the prevalence of abuse. And I just ask people and I give them that palliative care warning shot. And now I have a really difficult question to ask. Have you ever been abused? I had an elderly lady say to me just a couple weeks ago, Judy, yes, it happened, but that was the norm when I was growing up and it didn't really bother us. It just was what it was, which I found somewhat surprising. And on the opposite end of that pendulum, I had a gentleman say, when I asked that question, he just started sobbing. He didn't say anything, just started sobbing. And I knew we were going to have some difficulties with him too, because despite the education I provide about not taking this medication for mood or to fall asleep, it's really complex for individuals to feel better, feel psychically better when they take these medications, and to differentiate the difference between pain control versus mood changes. The other piece of the assessment that, again, I know you all know is the quality of the pain. Is it nociceptive, neuropathic, visceral pain? And frankly, the pharmacologic agents that we choose will vary. Nociceptive pain can respond nicely to some of the non-opioids if they're not contraindicated. And if the pain is moderate to severe, we use opioids. Neuropathic pain responds poorly to NSAIDs or acetaminophen. It responds to opioids. We tend to need higher doses. This is where we rely on adjuvant analgesics. Visceral pain in a cancer population is largely opioids and sometimes adjuvant analgesics. There's been a lot described lately about nociplastic pain. In these types of pain, patients report regional rather than discrete pain distributions. They have a lot of hypersensitivity, allodynia, and they have sensitivity to light, odor, sound. They have sleep alterations and talk about cognitive problems. Fibromyalgia is sort of the hallmark, but it may also include irritable bowel, interstitial cystitis, complex regional pain syndrome, or long COVID even. And we know that opioids are not an agent of choice for this type of pain. So the question comes then, if opioids are decided upon, which opioid? There are a wide array of opioids. Not all of these are available on our formulary, even in our inpatient setting here, or certainly not in most of the retail pharmacies. So the American Society of Clinical Oncology commissioned a clinical practice guideline committee, and I co-chaired this committee with Eduardo Barrera. And our charge was to provide guidance on the use of opioids, given this crazy environment in which we're trying to function right now. We explored systematic reviews and randomized controlled trials from 2010 to 2022, and we had a multidisciplinary panel. We attempted to answer 7 questions. So in the first, when do we offer opioids? Well, in moderate to severe pain. I know that's not rocket science, but what we did interject or advise our clinician colleagues about was that when you institute an opioid, you also discuss the goals. The goal is function. So functional improvement, not a change in pain intensity. And what are the expectations that we have for people when prescribing opioids? Which opioid? Well, honestly, in our very thorough review, we couldn't find any particular opioid that was preferred over another. One has to consider that patient sitting in front of you and the bioavailability of the drug, the route that patient may need. The head and neck patient who's going to go through very painful chemoradiation, who won't be able to swallow their own saliva, we're going to need likely a high intensity or high concentration liquid opioid that generally leaves us morphine or oxycodone. We think about the half-life, any organ system malfunction, neurotoxicity, and unfortunately more and more cost. Now, we did call out tramadol and codeine as agents that one would likely wish to avoid. Tramadol, most people don't even understand that it is an opioid. It's an opioid, a very weak opioid, and an SNRI. There is a ceiling. It lowers the seizure threshold, and it has evidence of causing dizziness, particularly in older adults. Well, I'll come back to codeine in a minute. We also wanted people to understand that if they are instituting methadone for pain control and they don't have a lot of experience, one should consult palliative care or a pain service for assistance. Now, what about codeine? Codeine's a prodrug, as you all know. It's metabolized through the cytochrome P450 system, particularly CYP2D6, and we know there's a lot of genetic variability, such that about, give or take, 10% of Caucasians, 3% of African Americans, and 3% of Asian Americans in the US are unable to metabolize codeine to its active component, which is morphine. So we also looked at the literature related to pharmacogenomics, and the decision was made to advocate we're not really ready right now to suggest that everybody should get screened. It just isn't available in all institutions, and the utility isn't quite there yet. Maybe 5 years from now, but right now we don't have the feasibility. So how do we select the dose and the duration? Again, not rocket science. You start low and you go slow, titrating up slowly. You start with an immediate release opioid. You do not add a long acting until that individual has some efficacy and you clearly understand that there are no adverse events or effects associated with that opioid. The general rule of thumb is at least a week of therapy. The only opioid that is long-acting that is approved in an opioid-naive patient is the buprenorphine or Butrans patch 5 micrograms. And I have used this successfully, particularly with older adults who aren't tolerating that roller coaster effect, if you will, of an immediate release opioid. And then when the patient needs dose increases, the general rule of thumb is 25 to 50% increases. But again, look at the patient in front of you. Rotation is a common phenomenon, particularly in the cancer population. So when do we do this? When the pain is poorly managed despite appropriate escalations or titration upward. I find many people will order an agent, it didn't work. Instead of increasing, they switch to a different agent. Same thing, they'll switch to a different agent, but never adequately titrating any of those drugs. Or if the patient has poorly managed adverse effects, again, despite our best efforts, then we may change to a different opioid. And then, unfortunately, at times I have to admit, we're doing it for the insurance companies. Now, I'm just showing one table here to highlight the quotation marks. These are not carved in stone. These are not based on randomized controlled clinical trials. And in fact, our committee decided we weren't going to even begin to tackle this. I sit on a different committee that's trying to find the one true equianalgesic table, and we've determined that that's not feasible. The truth is, each team should establish the gold standard for that team, whether it's using this kind of table or conversion factors, and everybody on that team needs to stick to that value so that there's continuity as different physicians or clinicians rotate on and off a particular service. So how and when do we taper opioids? This is becoming very common as well. So when a patient has been on an opioid for a very short period of time, it's very simple. You really don't need to wean gradually for most cases. There's a limited risk of the abstinence syndrome. But for people with chronic persistent pain who have been on opioids for a long period of time, we need to go slowly. I had a young girl who was treated at the NIH with a stem cell transplant, and she was discharged home on about 600 milligrams of morphine. And unfortunately, I was never 100% clear what the etiology of her pain was. It took 6 months to wean her down very gradually. And there were some bumps in the road, I have to say. I have another patient who was treated here for colorectal cancer or rectal cancer. Um, and that's a very painful treatment, again, using chemoradiation. And she was discharged from the hospital on 1,000 milligrams of morphine equivalents. And after almost a year, I am still very gradually titrating down. My job is sometimes as a cheerleader. The important rules of thumb are not to add other substances like benzodiazepines or others, but to optimize adjuvant analgesics and add other kinds of support and provide a very clear verbal and written plan. We're going to come back to some of the challenges associated with tapering at the final aspect of this talk. This is a nice document for those of you who are clinically practicing and looking for guidance. It's a couple years old, but it's really solid. It's from the VA and the Department of Defense, and it's available online as a PDF. So how do we prevent and treat opioid-induced adverse effects? Well, in the clinic, I am called the pain, poop, and pot nurse. Constipation is the one side effect where tolerance does not occur. So first, one has to conduct a very thorough assessment to rule out things like bowel obstruction. Our goal is a soft-formed poop every day or every other day, and we need to talk with patients about this and to be proactive because the public is mortified to discuss this, so we need to engage them so that they understand. We always begin a prophylactic regimen when someone's going to be on an opioid for a while, and that may include the natural vegetable laxative senna with or without docusate, and we titrate up. Um, it often I tell patients that that's often for the daily prevention, and sometimes we need dynamite. And the dynamite may include magnesium-based products, bisacodyl as a powerful laxative, or if you're clear that this is an opioid-induced constipation, we prescribe the Pamoras, peripherally acting mu opioid receptor antagonists that are designed to work only in the opioid receptors lining the gut. Now, I do have to say that some of the products, in my experience, have in some patients resulted in the abstinence syndrome. So while some of them, particularly the older one, methyl naltrexone, I have not seen this occur, with some of the others I have seen abstinence syndrome. And one of my patients had been using heroin in her life, knew very clearly what the abstinence syndrome was, and said, I'm going through withdrawal when I take this medication. So it must cross the blood-brain. And then we are treating patients with kidney dysfunction, an older population, a population where some of our agents may have really compromised renal function. And so what are the appropriate opioids to use in these patients? Well, the red light would be codeine and morphine, tramadol, and hydrocodone. The agents to use with caution might be hydromorphone or Dilaudid or oxycodone. The agents that appear to be safer include buprenorphine, fentanyl, and methadone. Methadone is the only opioid that is fecally excreted, hence its safety in renal dysfunction. And then how do we provide safe and effective care? It's a lot of education. Despite the fact that people have heard over and over again through the media about opioid overdose deaths, when I suggest to them that they need to lock up their opioid supply, they're really quite surprised. And don't quite see the connection. And I use the example, you may have a plumber or somebody come into your home, some patient to repair, some person to repair something. And if that person sees your medication sitting out on the kitchen counter, or if they know that you have cancer, they may actually look for it, especially if they have addictive disease. We prescribe nasal naloxone to everyone, but I have to say again, it's become part of opioid stewardship, so people check the box, but they don't take the time to educate patients what they are doing and why they are prescribing this and how to even use this device. And so I have patients call me up and say, Judy, I got this at the pharmacy. Is this my new allergy spray? So helping them to understand that this is used for overdose, that if overdose occurs, they need to spray it in each nostril and then immediately call 911 because the effects last for only an hour on average. And then this weekend, by the way, happens to be the DEA National Take Back Day. So many places are having drive-throughs where people can just dispose of any medication. And frankly, on a regular basis, most 24-hour pharmacies have kiosks that allow people to dispose of medications, no questions asked. We also advocate for universal precautions, which describe including checking the prescription drug monitoring program. You can often access this through your electronic health record, although it tends to be a lighter version of what's available on the actual software. I'm very fortunate in Illinois. I can access about 20 states through the Illinois prescription drug monitoring. We do urine toxicology, and I do it on everybody annually. I do the brief screen, and yes, it's flawed. There are a lot of false positives and negatives, but it is an expectation. The insurance companies, by the way, are asking me whether I do this when I'm applying for a prior authorization. They've never asked for the results to date, but they want to make sure that I'm doing this kind of work. And if I find something that's unexplained, then I will order the confirmation, which is liquid or gas chromatography or mass spec. That will give me a lot more important data. However, it's very expensive and it takes days to get the results. So be really cautious. So based upon that patient's risk, you base your structure. So for the patient who you determine has minimal risk, you might check the PDMP every 3 months or so. You get an annual urine tox. You make sure that you see them every 3 months. Now, we can no longer use paper prescriptions. In the past, we used to give patients 3 paper prescriptions that would be dated May fill June 1st, May fill July 1st, May fill August 1st. We can no longer do that. For people with higher structure, and that tends to be many of the patients that I care for, my oncology colleagues do a brilliant job with most pain situations, but when patients have complicated opioid misuse or substance use disorder, then I tend to see those individuals, or people with significant mental health challenges. I may do a urine tox much more often. I look at the PDMP every single time, and it isn't just punitive. If I'm worried about whether insurance will fill, I can see how many days insurance considers that previous refill to know if I'm still in the window. I reassess pain, function, aberrant behaviors regularly and reconsider whether it's safe to use that opioid. I have many patients where I can only use a 1 or 2 week supply at a time. Sometimes I'm able to engage the family who then might dispense the medication. Unfortunately, many people who have had substance use disorder are disenfranchised from family. We taper when indicated and refer to addiction specialists. Our challenge is they are few and far between. And so how do we put this together? We assess risk and stratify. We decide whether or not there's an organic etiology to prescribe and whether or not it is safe. We minimize the risk as much as possible. We monitor for drug-related behaviors, and we respond if those behaviors occur. Now, I know I've talked about opioids this entire time, but I also wanted to just focus on the fact that we are really using multimodal therapy whenever we can. So physical measures like PT, OT, rec therapy, etc. Integrative therapies, acupuncture, acupressure, music, mindfulness, interventional procedures, psychological approaches. And then, by the way, there are many apps, many of them free, that can assist with some of the mindfulness or guided imagery, and then other neurostimulatory techniques. I also wanted to call out virtual reality. Again, I'm relying upon the best source of medical information, the New York Times. This was from 2022, and it was a wonderful piece in the Sunday magazine about virtual reality and how it really has some promise in the treatment of chronic pain. And it's not just a distraction, but it can provide some long-term relief. So to finalize, I want to just discuss some complex cases and some unanswered questions that we have, again, in the clinic. And that's, how do we provide balance with some very complicated cases? And these are patients often called legacy or inherited patients. In these patients, the physician has retired. They can't find somebody else to prescribe. The practice no longer prescribes opioids. They won't accept pain patients into their practice. There is a lot of discrimination against people who have chronic pain. And what happens in the oncology clinic is that the primary care doc is probably breathing a sigh of relief and is saying to the patient, you have cancer now. Your oncologist will prescribe these medications, even though the pain is not related to that individual's cancer. So what we're seeing is that there are many people with chronic pain who are left with no medications. And the group headed by Philip Coffin, in your neck of the woods, by the way, describes mental health crises being much higher in individuals where the opioid has been stopped or tapered, and then overdose events very high after people who have had the opioid tapered. And indeed, we're seeing increasing rates of suicide as time goes on after the opioid has been discontinued. So what are their recommendations related to the care of these patients? I will say often they end up on your schedule, and you are told by the patient, I took my last opioid last night and my doctor told me to come and that you would prescribe opioids from now on. So in the best of all circumstances, review the case with the former clinician if that's feasible. In the case of people who have retired, it may not be. Don't promise right away that you're going to continue prescribing that opioid for that patient. But if they are completely out of the drug, you may give them a 1 week or a 2 week supply until they can provide you their medical records, just because abruptly tapering or discontinuing is dangerous. It's been shown to lead to illicit use, suicide, and hospitalizations. If you decide that it is appropriate to continue care for that patient, develop a patient-centered plan. We talk about tapering, and I give patients the choice. Shall we taper your long-acting first or the short-acting? These are difficult conversations, but if the patient has some agency in the decisions, we get a little bit better buy-in, and it may take a very long time, particularly for people who have been on opioids. And indeed, for the patients that I'm seeing, I'm trying to taper at the time that they've received a serious illness diagnosis and then may be experiencing painful treatments like surgery and radiation and chemotherapy. So then there may come a time when tapering no longer makes sense. You may need to plateau, and all of those are complicated decisions. So assess for opioid use disorder and discuss options. This is actually, again, a difficult diagnosis for people to accept. It takes time. And then document all of the stewardship that you've employed. I wanted to highlight some resources for you. This is a great article that they've written primarily for primary care, because many of our PCPs are actually carrying this burden as much or more than we in oncology. And this is a great website that Coffin and colleagues have put together that includes podcasts, all of the PDFs of the articles that they've written, and some other resources that many people find clinically very useful. So I found this extremely reassuring when helping to care for these very complex situations. So reducing it down to those clinical pearls, how do we balance pain control and risk reduction or harm? Always conduct a thorough assessment, including that risk assessment. The goal is no longer pain intensity on a 0 to 10 scale. It is comfort function. We optimize the non-pharmacologic therapies to the greatest degree feasible. We recognize the long-term adverse effects of opioid use over the long haul, and those include changes to the hypothalamic pituitary gonadal axis that leads to issues with fertility and libido and sexual performance and testosterone levels and possibly even fatigue and bone health. And of course, we see changes in sleep. So what people describe sleep disordered breathing as a consequence of long-term opioid therapy. So these are not innocuous agents. Employ universal precautions, wean slowly, and educate patients about safe storage and disposal. This is tough work for those of you who are clinicians. What can we do to sustain ourselves and maintain our compassion? Learn about substance use disorders as a chronic disease. Quite frankly, this was not part of my basic education. I've learned most of what I've learned in on-the-job training. And what I've learned is that substance use disorder is probably more fatal than many cancers. Be mindful of our implicit stereotypes and biases. We see it in particular expressed in relationship to substance use disorder. I mean, really, just look at the way we treat people with substance use disorder or with opioid use disorder in our country. People of color and people who are poor go to a methadone clinic. People who have insurance can go to their PCP and get a monthly dose of buprenorphine, while that person has to go to the methadone clinic daily. And for those of you who have ever investigated this, people who are selling heroin know clearly where they have a captive audience, and they will approach patients as they are lined up in front of that methadone program. So be careful about our words, use people with terminology, talk with experienced colleagues so you can move from feeling really frustrated to a more realistic engagement with your patients. Learn and practice motivational interviewing, which is tough. Don't worry alone. Find support to help manage yourself, your patients, and seek help if you or a loved one are in trouble. Now, why did I call this Pandora's box? Well, if you remember, Pandora was told, don't open this box, right? And what did she do? Much like Indiana Jones and the Ark of the Covenant, she opened the box and all flew out all of these furies and demons and devils and all the negativity of the world. Now, does anybody remember what was at the bottom of that box? Hope. So despite the negative message that I've been sharing with you, I do feel hopeful that we can overcome these challenges because our patients need this. So I want to open this up. I'm going to stop the share so I can actually see you all.
Thanks, Judy, for a fabulous presentation. All the pearls that we can take into the clinic. I'm going to take the chair's prerogative and ask you the first question. We've been doing a lot of work looking at pain in people with cancer, and these are people getting active treatment, not in the palliative phases of the disease. And the thing that's been coming up, I'm going to call multiples. And there's two multiples I think about. And I appreciate your sharing how you think about them in the clinic. One is we see people who are living longer with cancer. Maybe their disease recurs, but they're still curable. And they've got arthritis, they've got back pain, they've got other chronic painful conditions. And how do we think about that in relationship to the analgesic regimen? And the other one you started to allude to, but to me, in our work, it's hitting us in the face that patients with pain not only have pain, but they have multiple co-occurring symptoms. So a patient with a really poor pain profile, they're anxious, they're depressed, they're not sleeping, they're fatigued, they have cognitive changes. And how do you think about that in terms of these really complex people? And these aren't people with opioid use disorders, okay? They're people getting treated for cancer and come to the clinic with all these conditions. And I kind of feel like the oncologists are overwhelmed. They just don't know where to go with this. So I'd appreciate your thoughts about that.
Well, Chris, you and your colleagues have done the most work on symptom clusters, and you you've hit the nail on the head. This is what we see. And I think it's gotten to the point where many of my colleagues are frustrated in even asking about some of the symptoms because we have so limited interventions for fatigue, for example, right? And yet that's probably the most common symptom that our patients report. So yeah, it's a challenge. And indeed, with low health literacy, with the advent of the electronic health record, with crazy clinics where you've got 20 minutes at best and you're supposed to describe that next clinical trial, symptoms get kind of left. And frankly, we see that patients are being assessed more for symptoms by the nurses in the infusion suite, and yet more and more people are on oral meds, so they're not seeing those clinicians. So you're right, a lot of symptoms are just not being addressed. And people are reluctant to report because they don't want to miss that, qualification for a next clinical trial. Yeah. And then the issue of chronic non-malignant pain syndromes. Yes, cancer is a disease of aging in part. And so we see lots of people with lots of arthritis related pain and spinal stenosis. And now they can't take NSAIDs because, they're on Eliquis for their DVT or, other, anticoagulant therapies, and they've hit, the kidneys have taken a hit. So we prescribe low doses of an opioid so that person can move. And yet then we get the faxes, danger, you're prescribing inappropriately. So it is a tough time.
That's amazing. Mark Schumacher wanted me to ask you, do you use ketamine in your inpatient practice for opioid tolerant patients with cancer?
So, Mark, that's a great question, and most centers do. And unfortunately, we are only able in my institution to do it in a monitored setting, and we can't occupy an ICU bed. So, because our ICUs are just always overloaded. So, we've been trying to work with administration to institute some protocols. We used to be able to do some of these more aggressive kinds of therapies when we had a palliative care unit and all of the staff were trained. And sadly, that unit was closed probably 10 years ago, again, for financial reasons.
Did the ketamine work?
So that's really interesting, Howard. I've not seen it, but is that patient selection?
Okay.
I've had a couple patients where they've gotten admitted to the ED, and the ED is a place where they will give ketamine, and I've not seen it work.
Okay.
So there are some
questions?
people who swear by it.
I have a couple of questions. I
go ahead,
loved
Howard.
your talk. It was really very good, very eloquent and accurate. And it's really helpful to have had your experience with the patients. And there's no substitute for that. There were several medications that you didn't mention at all, some of which I've used. Tapentadol, Dilaudid, well, you did mention Dilaudid. Levorphanol is another one that's out there. Then there's the one that is most interesting to me is Duragesic, the transdermal fentanyl, which, when I was younger and still in practice, that was used a lot in palliative care. So I just wanted to have your opinion about that. And then I've got another question about tapering, but I'm going to put that off for now.
Sure, we use fentanyl patches all the time. There is
Okay,
no
great.
Duragesic. Yeah, there's no Duragesic anymore. There's very few opioids that are trade name. Tapentadol is the exception. I do use it in a few patients, but I will tell you it's about $600 to $700 a month.
Oh,
And
God.
it's very expensive and very hard to get a prior authorization for that.
Okay. All right.
Yeah, and
Okay,
levorphanol is not available. And ironically, the insurance companies list that as an alternative. Like if I try to order oxycodone extended release, they want me to use levorphanol, but no pharmacies in my area of Chicago carry it.
Yeah. Mike Robotham did a beautiful study that was published in the New England Journal, using levorphanol for neuropathic pain. And he showed that there was a dose-related improvement over, 3 months or so, which might be absolutely appropriate for your cancer patients. So that's why I brought it up.
I think
remember it, yeah.
Before the long-acting opioids were available, we used levorphanol a lot. And before we understood methadone and its pharmacokinetics and pharmacodynamics. But like Judy said, it's a hard drug to get. And
Yeah.
I think when I first came to California, there wasn't much use of it. It was much more common on the East Coast. So you had another question about tapering, Howard, you said?
Yeah. Well, yes. So one of the things about tapering is the reason you do it is that the hypothesis is that the opioid's actually making the pain worse, right? That's the point of tapering. And it definitely is the case that there's been no study that's actually shown in a large trial that tapering actually improves any patient's pain. But there's a lot of anecdotal studies to that effect. Some patients, you can lower the dose and the pain doesn't change. Some people do get better. Some people do get worse when you taper, right? Am I wrong?
So, there's the very clear population, like that woman who left the hospital on 1,000 milligrams of morphine equivalents. The disease is gone. The treatment effects were dissipating. There's a lot of mental health challenges. Same thing with the patient who was released from the NCI.
Yes.
So with those very high doses. But you're absolutely right. I have a large population of patients where it's sort of harm reduction. I just continue them on the dose when it's not super high doses of an opioid.
Yeah, the irony is that in the addiction field, two of the major treatments for opioid use disorder are opioids. Buprenorphine is a mu agonist. Methadone is a mu agonist. That's long acting, and that seems to be okay. Whereas morphine or whatever other opioid you want to use, that's not so okay.
Yeah.
So.
Yeah. You're going to hear from Jessie Merlin at the next presentation.
Oh, great.
She speaks a lot about buprenorphine. She is a strong proponent of buprenorphine.
Yeah.
Judy, I'd be curious to know more if you've heard about that Advert D. I saw the press release on that and tried to dig deeper into like the FDA website, try to go find the clinical trials for the company that got this approved. The literature was absent. And I don't know if it's been, since it came out in what did you say, in the New York Times last week, is there uptake of this? Do you think it's going to be used to screen patients?
So I sit on an AMA committee. I represent ASCO on this. It's called Pain and Substance Abuse or Substance Misuse Committee. And we've actually begun conversations about how we need to respond to that and a few other regulatory issues related to opioid access.
Yeah, I'm June 4th, I'm going to be an oncology nurse 50 years. And hearing your talk, I feel like we're back 50 years ago.
Me too, Chris.
The pain in the cancer patient is extraordinary. The fears are all back.
Yeah.
It's really, really, really challenging. And it's like we've gone back 50 years. And it's depressed. You gave me a reality check with the beginning of your talk, and now I'm validated and depressed.
Yeah, sorry about that.
Well,
you don't use opioids for that.
There is this group called Physicians for Responsible Opioid Prescribing that's been very involved in trying to push to stop using opioids on various principles.
We know about that.
The number one is they don't work for chronic pain, right? Number two, anybody that's treated is at risk to becoming an addict, right? So everybody should be tapered, whether they want to be or not.
Whether they need to be or not, right?
Right. And then what happened was that they were part of the CDC, developing the CDC guidelines, which got translated into a lot of laws in various states.
I lived through that, Howard.
With no factual basis.
Right.
Anyway,
And it's just
totally-
proliferated.
I so
Yeah.
appreciate hearing from you and Chris about this, because you guys are still in the trenches. It was never a problem for me. I used opioids, and I would say about 30% of my patients, I almost always use them with an adjuvant drug, like
Right,
an
right.
antidepressant.
But you were special, Howard. I mean, I don't know if Judy agrees with me. I think the work that we did through the AHRQ, AHCPR, whatever the hell it was, guidelines on cancer pain, we moved the needle on the medical oncologist in terms of managing pain. And now I think we're back to 50 years ago.
Yeah.
They're not getting, the young trainees are not getting educated in the setting of cancer pain, how to correctly manage people. I
Yeah.
see that all the time in the clinic.
Yeah, one of my heroines in all of this was Kathy Foley, who I knew very well,
Right. Oh, yeah.
who was a neurologist. And
We knew Kathy very, very well.
yeah, I mean, really,
She was on the
just a-
cancer pain guideline
just
that I
a
shared.
brilliant woman,
Mhm,
very diagnostically astute,
mhm.
right? And she used opioids,
Right, but Howard, Kathy was a neurologist. She was not an oncologist. Okay, and she tried to reach out to the community. And
Well, no, but she was working at Sloan Kettering.
Right, but she was a
working with
neurologist. She was a
cancer
neurologist.
patients.
And if you
Yes.
talk to Kathy Foley, she would tell you the oncologist wouldn't call her to take care of the patient.
Oh, I did. I'm so glad I tuned in. Not just for Judith's lecture, but
Kathy
this
would
little
talk about this all the time.
this little vignette is priceless.
We just have
Thank
too
you.
much history. Judy and I should write the history of cancer pain management.
Yeah, it's too bad you're not here in person. We could go out, have a few drinks and dinner. We could talk all night.
Yes.
But I think the point is we have to change the paradigm and how
do we do that?
Well, I think one of the conversations PARC needs to have is about how we do this in the cancer community, in our cancer centers, and out there in the oncology community.
Yeah.
And to me, bone mets pain has been pretty well handled. The challenging pain for the 21st century is neuropathic pain, and then people with multiple chronic pain conditions.
Yeah.
I mean, they're as complex as a substance use.
Right. But maybe some of these new, these new ligands for, or antagonists or blockers for voltage gated sodium channels like NaV 1.8.
Mm-hmm.
Now there was a paper out there saying, look, it works for standard pain models. So there's proof of concept there. And it would be interesting to see that, well, in the old days, you remember, pancreatic cancer, you do a celiac plexus block,
Magic.
You can't do, they used to do chordotomies, but that really didn't work, so you just hope that all that sort of accumulated knowledge in the field isn't forgotten. And I guess it's up to us old folks like me to remind people that, we've been dealing, well, you did it too, 50 years, me too, 72, yeah. 52 years
Well,
after.
Howard and I have monopolized the conversation. Any other questions? Because we're at 8 minutes after the hour. And anything else? Bill, Peter, anybody else? I can't see pictures. And Kathleen?
The only thing I can add is, Judy, I think we need some new drugs. And
I agree.
Yeah.
I agree, Bill.
every single
Yes.
day, I'd love to tell you, maybe in person sometime, maybe in Amsterdam this summer, we can talk about some of the things that I'm working on.
That would be great, Bill. Yeah, we do need new. I was going to say that when Howard was talking. We need some new drugs. Absolutely. Some new analgesics, right?
Yep.
Yeah, I agree 100%.
Why don't we have a little retreat on that? PARC retreat.
That would be great. Yeah.
Okay. Oh, okay.
We'll put that on the agenda.
on the
Mark
list.
left. Yeah. So new analgesic.
Maybe we could even get a sponsor.
Yeah, that would be fun to talk about. Right?
Okay.
Alyssa's
Wonderful.
saying yes, she's got her hand up. So Well, thank you all for coming. Judy, a million thanks to you for
Our
sure.
Great
pleasure.
to
It's
see
been
you.
fun.
Great to
see
see you
you.
again. I hope it's not that long before I see you again.
I agree. Take good care, everybody. Thank you.
Bye-bye,
for the
everybody. Have a great
invitation.
day.